Good evening, everyone. I'm Dr. Dhriti Bhatia. I'm an orthodontist associated with Dental and Academy of Dental Excellence since 3 years, more than 3 years now. So this is my first webinar, and I'm taking it on the behalf of Academy of Dental Excellence again. Due to this all difficult times, as we all know, we are not able to be, able to stay positive, but we have to stay positive and see towards the future. As the future says, is all digital. So the Academy of Dental Excellence, uh, are taking everything digital. Dr. Tanveer and Dr. Gunita have taken the step, uh, and they are taking the academy digital by taking all the courses and practical sessions online. As soon as this as soon as this free webinar session is gonna get over, we'll be starting a proper course. We'll be announcing various modules for all the courses, which will have all detailed lectures as well as the our practical sessions. We'll be giving live demos so that you can understand each and everything while doing the patient. We'll also be doing one-on-one classes for the doubt sessions so that you can get thorough understanding of each and every subject, right? So today we'll be discussing, so my topic today is little interesting. It's about brackets, from brackets now and then. So we'll be discussing about brackets. With every year, there's new changes. There are new upcoming things with new technology and all. So it's all exciting to, and all the advantages they are giving us. So today we'll be discussing brackets since starting till now, what all differences have been there, and advantages and disadvantages of bygones and the upcomings, and that's how we're gonna do. So let few more people get join and all, and then I'll start it. Okay, and just let me know if you can hear me or not, right? Are we ready for it? So brackets now and then. So brackets from the one of the most important component of orthodontics, fixed appliances, right? So they act as forces to apply on the teeth. So they are like the handle, which act as handle to apply the force through wire or any active component. As early as 1000 BC, attempts were made to treat malocclusion. But it was in era 1855 to 1930 where we saw the introduction of the brackets. The first bracket was ribbon arch brackets, which were introduced in 1916 by Edward Hartley Angle. The classification of brackets are according to the type we are using. Maybe let's say the material, which is metal, ceramic, plastic, and titanium. Then it is also classified according to the type of slot. Slot, either it can be ribbon arch, which is vertical slot, whereas edgewise is a horizontal slot. Then there is a combination slot that is seen in tip edge mechanics. Based on the bracket design, the design these days, because of introduction of CAD and CAM, we can incorporate tip and torque in the bracket, right? First, we used to do all the tip and torque through the wire. Now the torque can be introduced either in face or in base. Then we have new generation self-locking mechanics, which can be passive or active. Then based on friction, it could be medium friction, maximum friction, or minimum friction. According to slot, we have two of the things that we generally use, overnight or O2 slots, based on the attachment on the tooth. First, like before the adhesive, the composite came, we used to weld the brackets on the band, and then we used to cement it. But now we just bond the brackets through self cure or light cure. According to Andrews actually gave a lot of brackets, non-programmed, partially programmed, fully programmed. It has like generations of Andrews pre-adjusted edgewise appliances. So evolution. So first who gave was the pure Forchard in 1900s, found out if a rigid framework of tied to tooth, the arch could expand and dictate the appliance. So this was basically done to expand the arch. And this is the E-arch appliance that I'm talking about. So if you can see this, the circular one on the PPT, this was used to expand the tooth, expand the whole arch and get more space and get the teeth aligned. This appliance used to use stationary anchorage, that is either headgear and all that, which the hard anchorage. It used to expand the arch traction screw, but the problem was we couldn't we couldn't control the tooth movement. Like now the brackets are so made that you can control the force you're applying, the tooth movement you want. In this, there was uncontrolled tooth movement, and there was lots and lots of resorption seen. Then came the pin and tube appliance. Again, it was given by Angle. So most of the teeth were banded because we didn't have GIC at that time. Vertical tubes were soldered to the band with their long axis, parallel to the long axis of the crown. So the vertical bands are like the pin and tube appliance was a vertical slot, and it was banded onto the crown, and the forces were applied through the wire. Rational movements were difficult to obtain, that is, the mesiodistal and buccolingual rational movements were difficult. Then came the ribbon arch appliance, which was given in 1915 by Angle. This was a big step in evolution. The advantage was rotational movement was possible. Buccolingual and incisor-gingival movement was possible. The disadvantage was distal tipping of the buccal segment and mesiodistal axial movement was not possible. Arch wire don't provide a stabilized, like you need a hard anchorage or stable anchorage for it. And then came the beg. Begs is generally modified ribbon arch appliance. It is the brackets are same with time, okay, so Beggs was given by Raymond Beggs, who was a student of Edward Hartley Angle. But what was the difference between ribbon arch and our Beggs? So the difference was the slots, although were vertical, but they were upside down. Angle used to use it as like on the occlusal surface, whereas Beggs used to use it on like the slot were opening on the gingival side, right? So what was all the advantages of Beggs, which I also, so it used to use light force, there was tipping movement, there was very less friction, no unwanted resorption was there, but there were few disadvantages also. There were lots and lots of wire bending that we had to do. Then there were the time, chair time was increased. The whole treatment time was also increased as well, right? And torque was totally impossible. You have to put lots and lots of auxiliary on each and every tooth you want to give the torque. So which was very much time consuming. Then came the edgewise appliances, right? So the final bracket designed by Angle based on his line of occlusion concept. It had a rectangular slot. The movement was possible in all three planes. Twist torque has to be shaped in the arch form, but it was all done in all three planes. The only disadvantage was it was time consuming and it used to look like a little artificial smile. So before I go directly to the new things now, you need to know what is tip, torque, and few things that you're gonna listen a lot in next few slides. So tip is mesiodistal movement of the tooth on the long axis, right? So the positive tip means mesial crown movement and distal root movement, right? And you can see a diagram over here. So a mesiodistal, like this is the mesiodistal movement of the tooth according to the angle of the long axis of the tooth. So this is the mesiodisc. This is the tip. Now the torque. Torque is defined as a relationship of crown and root inclination perpendicular to the line of occlusion. So this is the line of occlusion. This is torque, right? So this is our whole axial line. This is the occlusion line. So this amount of angle here will be the torque, right? Now positive torque is labial crown movement and palatal root movement. You need to understand tip and torque to understand the newer techniques and pre-adjusted edgewise system. So where are we now? Basically is we are using pre-adjusted edgewise bracket with a better understanding of tip and torque. So with better tip and torque is MBT brackets. Then there was ceramic brackets with same tip and torque. Lingual brackets are used with different. Lingual bracket is something new and we are exploring more about it. Then there are self-ligating brackets and aligners. So first you need to understand is the treatment mechanics. How do you do it? So how do you select a patient or the system you want to use? First you have to see the bracket selection. Then you have to see the archwise selection according to the arch form of the patient. Then you have to check the bracket positioning. Then the force level you want to give on the teeth according to the periodontal health. So first, a pre-adjusted edgewise bracket system was given by Andrews. It was the first generation pre-adjusted edgewise system. It had a traditional feature of Siamese edgewise bracket. The disadvantage was there was a lot of tipping and rotation into the extraction side. There was a bite opening, if you can see here in the PPT. So there's tipping in the extraction side and there's bite opening in the premolar area and increased curve of speed. So this is known as roller coaster effect, which was due to increased tip in the brackets of first generation pre-adjusted edgewise. So these early clinical experience led Andrew to introduce a series of modifications. Like in third slide, I told you Andrews gave 3-4 form. So he originally standardized straight wire appliance for a period of time. He recommended a wide range of brackets. Then came the Roth. Sorry, Roth was second generation pre-adjusted edgewise because he didn't want to use all sort of variation and get all confused. He wanted a single system appliance. So consisting that he can treat all the patients without extraction. So he made only general 2 set of appliances, extraction and non-extraction cases. In Andrews, arch form was wider in order to avoid damage to canine tipping during treatment, and true arch form was followed. Roth started treatment with Andrews bracket and altering the values according to the need. Bracket identification marks were changed, auxiliaries were added in the brackets. That's how it evolved. Roth setup is generally used O18 and O22 slot, whereas O22 slot is more precisely used with today also, because we get more advantage on wire selection, stabilizing arches as anchor unit, and for control of torque in the buccal segment, which is very important for standpoint of functional occlusion. So overcorrection in Roth was done. Not much overcorrection in lower to avoid cuspal interference, whereas there was increased tip was given in upper anteriors only. Then he also changed the torque, and he also changed the tip to not to rectify the roller coaster effect which was happening in Andrews. So what he did, the upper buccal segment are distally uprightened to 0, which you can see here. It was uprightened to 0, whereas the lower segment has given and 3 additional distant tip. So difference between Andrew and Roth setup. So Andrew was center of clinical crown of all the teeth chosen as a horizontal reference plane. Roth also chose the center of clinical crown of bicuspid and chosen as horizontal plane, where that is the point where you want to put the bracket. In Andrews the torque was in base, whereas in Roth's the torque was in face. Too many bracket sets, depending on different cases, was given in Andrews, whereas less inventory was needed for Roth system. Case to be treated strictly according to Andrews 6 keys of normal occlusion, whereas in Roth, case treated according to patient's profile, facial balance and harmony, which now we generally see that we treat the case according to patient's profile, facial balance and harmony, and more we consider more about aesthetics. So Andrew's philosophy was translating teeth without tipping them, that is bodily movement. It is not possible to precisely position the teeth in occlusion before appliance removal because of bracket interference. However well the case treated, it would show some relapse after appliance removal, whereas Roth believed some amount of tipping was required for effective translation. By altering the position of bracket, it was possible to achieve ideal occlusion as non-orthodontic normals. By treating the case to slightly overcorrect the position, it was possible to avoid relapse. Now come the MBT. MBT is nothing but MBT's full form is there are 3 people, McLaughlin, Bennett, and Trevisi, who came together to form a better generation of pre-adjusted edgewise. They went through a lot of cases and redefined uh, tip and talk for each and every tooth, and they also redefined the talk. Instead of talk in face, they gave talk in base, so that the slot up placed in one position to the whole arch. So redefine treatment mechanics based on sliding mechanic and continuous slide force. Treatment mechanics recommendation included accurate bracket positioning, lace backs and bend backs for early anchorage control with light arch wire forces. Bracket positioning at center of the crown is important. Arch form is generally used, avoid. So bracket positioning with gauge are done. That is the bracket positioning gauge. 3 arch form is generally used. Tapered, square, and ovoid. Updated light force and sliding mechanic is used. MBT bracket is recommended as a modern version of pre-adjusted edgewise bracket for use with continuous force, lace backs, and bend backs. So in MBT, there was very less resolve was seen, plus the force was so light and the sliding mechanics was used, so it was easy to complete the treatment in 1 year. Even the extraction cases, you can complete the treatment in an year, whereas all the others it was difficult because although the light forces were used, tipping mechanics were used, but there was too much of inventory needed, wire bending and all that was needed, which just increased the chair side time, and also the treatment time was elongated. So torque and base was used because of the CAD-CAM technique. Now we can incorporate the torque in the base instead of the face, and we can have slot all at the same level, right? So there are 7 versatility that we generally use in MBT. That is palatally placed upper lateral incisor torque option for -10 degree. So what do we mean by that? That if the lateral incisor is palatally placed, we can use -10 degree torque incisor, upper lateral incisor by doing either using it upside down or just taking the opting for a lateral incisor with a torque option of -10 degree. There are 3 torque options for upper canine according to the need of the canine uprighting. And then there are 3 torque options for lower canine, again for the same reason. You can interchange the lower incisor bracket because they have a 0 tip and torque value. Interchangeable upper premolar brackets because they have same values. Then you can use upper second molar tube on first molar with non-headgear cases. So these are like interchangeable. These 4 are interchangeable, if you can see in the PPT. And then the premolar, upper premolars, you can interchange. Then you can use the second molar's molar tube for the first molar without a headgear, where you don't need to use headgear tube, or when you don't need to use headgear. So use of lower second molar tubes for the upper first and second molar of the opposite side. That means, let's say if you want to use a right side second molar tube for the upper first and second molar left side. If you want to complete the whole case in class 2 molar relationship, it's little, it is a little more, I'll have to explain it, and we don't have that much time and it doesn't cover in it. So I'll just explain a little. If you don't want to change the molar relationship, so you can use the lower molar tubes also, because they have 0 amount of offset. In MBT we have 5 degree offset in molars. Now comes the ceramic. So ceramic bracket are the most recent advancement in the aesthetic bracket, which was first introduced by Michael and Schwartz in 1987. The classification is again according to the material used, that is monocrystalline or polycrystalline, according to the retention, chemical, mechanical, or both. Then material constitutes, that is pure ceramic or laminates, that is zirconia. So first is monocrystalline. Monocrystalline is generally the chunk of alumina is used, but the way it's been manufactured, it has surface roughness and micro cracks predisposing to the brittle nature of the bracket. So while we were using these monocrystalline bracket, there was tendency to fracture and frequently, seen in the first generation of the ceramic brackets. So we are not using it. Then came the polycrystalline and the single crystal ceramic. All the current available ceramics are composed of aluminium oxide with particle size of 0.3 micron. One type is polycrystalline, made of sintered or fused aluminium oxide particles, and other contains a single crystal of aluminium oxide. The advantage is it is easy to manufacture. It is the ability to mold bracket is relatively inexpensive, and you can easily get them. But the disadvantage is the presence of structural imperfection. Then there is impurities present, and the opacity is not that great. You can see the opacity. There's too much of opacity, so it is not actually helping you with the clear, like we say, clear brackets. So it's not that clear. Then was the zirconia. Zirconia, as we know, is given for strengthening mechanism. So the advantage was it was aesthetically very proper, dimensionally stability was there, durability and resist staining in the oral cavity, which is very important in India. And it was used in patients who were allergic to nickel. But the disadvantage is again brittle and therefore fracture or crack when undue forces are applied. To compensate for their brittleness, the size was increased, but then there was increase in the bulk, and there was too much of friction seen. Enamel abrasion of opposite teeth it was of high cost. Then came the metal reinforced ceramic. If you can see in the PPT, there is a metal slot. The whole bracket is of ceramic, but there is metal slot in between. So it helped with strengthening. It also helped with less friction. It was a better bracket, but the problem was while debonding, there was a lot of enamel chipping was also there. So now the advanced ceramic brackets have an objective where there is maximum bracket adhesion bond strength, minimum friction, and provide superior bond durability by using an epoxy resin base with high specific addition to the most orthodontic adhesives. Now is the self-ligation. So what is self-ligation? So self-ligation are the bracket defined as a bracket which utilize a permanently installed movable component to entrap the arch wire. So these are the conventional arch wire. If you can, conventional ligation, if you can see, they are using ligature wires, and here the gray, this thing are the modules, right? So these are the old things that we were using. What is self-ligation? So in the bracket, they have incorporated a fourth wall. This is the first, second, third, and this is the fourth wall to entrap the wire. From the slot goes the wire, and it is closed. So you don't have to put the modules or the ligature wire. It is done by the metal wall itself that is incorporated in the brackets, right? So self ligation brackets are of two type, passive and active. This one in the PPT, you can see it is a passive one. So what it does, it passively close it, but do not put any pressure. One more is the active one, which is also known as C-clip, Damon C-clip. That is the kind which you can get in the market, which put force also on the wire to get entrapped. So what are the benefits of self-ligation? So aesthetics, some design permits significant miniaturization. That is, they're very small and you don't see them. Whereas in conventional ligature, they are big and you can see them, all metal. You can see it very prominently. Force level, use lighter force. The conventional ones, you need heavier force. The force delivery is very light initial force, and whereas in conventional one there's high initial force that's been seen. Friction is very less, whereas in conventional ligature wire, if you're using, it's high. If you're using elastomeric, it's very high. Infection control is reduced, whereas in conventional one there is too much of infection control. There is too much of risk of infection, and because the patient is not able to clean the modules around the modules and ligature wire, it's just not the oral hygiene is not you cannot take care of the oral hygiene. And treatment time, which the most important thing is the treatment time. Overall time reduced by about 4 months, whereas in conventional one you need a proper 1.5 years to get completed. Now come the aligners. Aligners are alternative to traditional braces, but similar to pre-adjusted advice system, aligner use the gradual force to move teeth into the required position. These are made of strong plastic material fabricated to fit each person's mouth. So the advantages in it, there are so many advantages of aligners, and with the just increase in technology and all, we can just treat any sort of patient, any sort of malalignment. But the only problem with aligners that everyone is facing is it is just dependent on the patient, right? So you have to be dependent on patient's compliance, and you cannot just directly you're just dependent on the patient, and you cannot think if patient is not wearing it, there'll be no changes, and it is expensive. So you need to be very much dependent on the patient, and he has to cooperate with you. Whereas in conventional one, you can, after every 1 month you see the patient, but in aligners you just give the whole pack to the patient, and you need to see him after, let's say, 5-6 months for the regular checkup and all. So that's the changes that you have seen. And then there's this lingual appliances that we've been using. It is a new thing, but the problem with them is one, it is little expensive, plus patients are very uncomfortable with it. Although with I think with increase in technology and more time, with a little more time, I think we'll be able to make some comfortable lingual appliances which will be which will help us in booming the orthodontics, I think. So now I'm ready to take all the questions if you guys have any. Online course will be starting with the online courses as soon as our webinars will be ending, right? uh, keep in touch with the academy, and I'll just share the academy's number and everything. You can call them and ask the procedure, and they can tell you all the courses that we are running right now online. They'll help you about it. They do. So they actually give equally good results. With betterment in technology, we are able to treat difficult, even the class 3 cases with aligners these days. So yeah, if the patient compliance is good, I think we can treat the patient with the aligners these days. I have a daughter. Sir, I would like you to show the get your daughter to our clinic, and we'll just check. We'll just go through all the dentition, all the things. And yes, if there is gap in everything, you should go to a dentist, and especially orthodontist, to get it checked once, so that if there's anything, let's say the gap, if it's too much, so a little bit of gap is normal, but if it's too much, we need to check it right now, and we need to give the modulators, which help in just changing the shape and changing the shape of the arch, and so that the teeth can come in the arch. So actually, the braces are done after 10 years, but you should come with your daughter or son to clinic to just show, if even if there is any malocclusion occurring in the early age, we can start the treatment, and we can just stop the malocclusion. So the good age to come is 7 to 8 years, because at that time the malocclusion is coming from deciduous to permanent, which we can just stop the malocclusion. We can stop it there, and we can help the growth of the arch, and we can use it. Sorry, sir, I just missed your question. Um, sure, there's no age limit for the braces. There's no age limit for the orthodontic treatment. So we have treated cases from, let's say, 10 years to the last one I have is 50, 60 years of age. If you're concerned about the aesthetic, you can even go for ceramic, which is teeth shaped, tooth colored, and also you can go for aligners. So now there are techniques like self-ligation, which help us in expanding the arch. It's not always important to extract the teeth, but you have to show it once in the clinic to get the firm answer about it. Aligners are anyways anytime better than braces for if you're traveling a lot, of course, because you cannot come to the clinic and get in touch with the orthodontist. So yeah, they are better if you are ready to wear it for like 16 to 18 hours a day, and it's super comfortable. I think it's better. Thank you, ma'am. So with braces, you need to take care more of your oral hygiene. So what you generally do, what we generally ask the patient is, After braces, after having eaten every meal, just go and rinse your teeth with normal water. Plus, if you're eating something sticky or anything that's just stuck in your teeth or braces, just go and brush. So I'll just say 2 times a day is least. But if it's possible and you're able to carry your brush along, so 3 times with every meal. That's it. Thank you so much for joining the webinar, guys. It was amazing. Thank you so much.